Good afternoon, class. My name is Sarah Uko. Today I'm here to present substance use disorder in pregnancy, and the drug of choice that was assigned to me is Oxycodone. So generally, I'm going to talk to you about the epidemiology of substance use in pregnancy in New Jersey and also in the United States. So let's get started. Opioid is a narcotic that includes strong prescription for pain management such as oxycodone. In 2019, the New Jersey Substance Abuse Statistics reported 98,479 hospital admissions on substance abuse treatment patients. 68% of these patients were men and 32% were female. In New Jersey, Ocean County, Camden County, and Essex County have the highest rate of women with substance use disorder. The drug overdose death rate in New Jersey amounts to 32.1%. Common substance used by pregnant women in New Jersey are heroin, which is about 59.8%. Opioid use is 9.7%. Marijuana use is 13.5%, and alcohol is 9.3%. Epidemiology of opioid use in the U.S. Increase in use of opioid from the 1990s to the 2000s noted among women of reproductive age. In 2008 to 2012, one-third of reproductive age women were given a prescription for opioid regardless of insurance status and annually. Increase in use noted among pregnant women. Opioid use in pregnancy leads to neonatal abstinence syndrome and congenital disabilities and preterm labor. Female is likely to use a substance during their childbearing age from 18 to 44 years of age, and 80% of women's pregnancy is unintended. From 2000 to 2009, data from the U.S. Department of Health and Human Services Substance Abuse and Mental Health Services Administration Center for Substance Abuse Treatment reported increased use of opioids from 1.19 to 5.63%. From 1999 to 2010, the Center for Disease Control and Prevention (CDC) reported an increase in death from prescription opioid overdose from 1,287 to 6,631, and accounting to a 400% increase over the past 10 years. Maternal, perinatal, and fetal risk. I'll start with maternal risk. History of alcohol, nicotine, and illicit drug use, unemployment, younger age, comorbid physical and mental health problems, childhood trauma, environment and stress, intimate partner violence, lack of knowledge of the impact of substance on fetal development, easy access to opioid. Perinatal risk includes women with opioid use disorder are less likely to receive prenatal care. Barriers include comorbidities, poor communication, stigmatization, placenta rupture, fear of being reported to the police, losing child custody, lack of trust in the healthcare providers, negative psychosocial environment, preeclampsia, and preterm labor. Fetal risk are neonatal abstinence syndrome. The infants present with tremor, irritability, excessive crying, diarrhea, and seizure. The rate in 2000 was 1.2 in 1,000 hospital births, and in 2009 the rate increases to 3.39 per hospital birth in 2009. Poor fetal growth is about 10% and preterm birth is about 8%, and it is a public health concern. Neonatal tube defect is also the risk factor for a child born with the mother using oxycodone. Another congenital risk factor for this child is this possibility of a child having an intestine or an opening just above the umbilical cord. Screening tools include is the same with what we use with other general population, which is the standard screening tools recommended by Addiction Research Foundation in 1982. The format of the tools is for a yes or no answer, asking the individual if they use substance for the past 12 months, up to 10 questions. A 0 means there's no use of substance. 1 to 2 indicative of substance use. Monitoring and reassessing 3 to 0.5. Moderate and further assessment is required, and investigation referrals. 6 to 8% is intensive assessment is required and referral for treatment. 8 to 10 indicate intensive assessment and referral for treatment. Other screening tools is from National Institute on Drug Abuse Research Guide. Also, you'll be able to use for an assessment of women with substance use disorder. Subjective presentation of the patient include client reported using drugs a year after injury and lower back surgery was performed. Client uses 10 milligrams of oxycodone 3 times a day with no relief, increases it to 60 milligrams in 24 hours. The client reported going to different providers, presents with anxiety, euphoria, depression, and panic attack, fatigue, nausea and vomiting, abdominal pain, itchiness, sweating, loss of appetite, and difficulties breathing. Objective presentation of the patient include assessment using drug abuse screening tools, the DAST-10 score of 8, a 38-year-old female with no insight about drug use, urine test positive for opioid oxycodone. Results from state prescription monitoring program indicate that the patient is receiving prescription from different providers. Differential diagnosis for this client will be anxiety and depression. Prenatal care and monitoring for each trimester. Prenatal care and monitoring, screening and assessment on each prenatal visit and throughout prenatal pregnancy using the brief, intensive, and referral for treatment, and continuous screening throughout pregnancy. Refer to treatment center when positive. Provide comprehensive and holistic care. Engage individual in a conversation, providing feedback on the importance of treatment for the unborn child. Provide a non-judgmental and supportive counseling. Use motivational interviewing and cognitive behavioral therapy. An opioid antagonist therapy such as methadone maintenance therapy is recommended. Give the woman chances of less complication and having a healthy baby compared to women who continue to use opioid. The use of methadone maintenance therapy MMT reduces spontaneous abortion and miscarriages and having a child with low birth weight and neurobehavioral issues. MMT reduces the chance of rare adverse effects. In 1998, methadone was adopted as a safe treatment for women pregnant with opioid use disorder. Physiological effect of opioid use in pregnancy: euphoria, nausea and constipation, respiratory distress, and meiosis. For pregnant women with an increased HCG, and opioid use lead to increased nausea and vomiting and respiratory distress and may result in dehydration, fetal distress. Psychological effects of opioid use in pregnancy include increased anxiety, depression, guilt and shame. Psychosocial stressors include physical, emotional, and sexual abuse. Legal effects of opioid use in pregnancy include potential loss of the infant custody. Some states consider use of drugs while pregnant as criminalizing and is considered child abuse. Here are my references. Thank you. Looking forward to reading more discussion from my classmates and learning from them. Thank you for listening and have a wonderful afternoon.